Finally, let's conclude our discussion of hormones by discussing where they act in the kidney. Some hormones are secreted from other parts of the body but act on the kidney, such as atrial natriuretic peptide. Now, why would other parts of the body need to communicate with the kidney? Well, two main reasons would be to regulate the blood pressure and regulate solute concentrations, since these are two things the kidney has a lot of control over. Atrial natriuretic peptide, which is secreted by the heart in response to increased atrial pressure, causes increased GFR by dilating the afferent arteriole. This leads to sodium and water loss, bringing the blood volume back down. To remember the effects of parathyroid hormone, just remember that this hormone's job is to increase serum calcium and decrease the serum phosphate. PTH acts in the proximal and distal tubules as well as the gut. Some people like to remember PTH by calling it the phosphate trashing hormone. Even though that's not what it stands for, it's a good representation of how the hormone acts in circulation. Can you recall which hormone opposes PTH? Correct, calcitonin. And where is calcitonin secreted from? The parafollicular C cells of the thyroid. This hormone acts to decrease serum calcium levels. And just to tie in one more integration, what endocrine tumor produces calcitonin as a marker? The answer is medullary thyroid carcinoma. You can revisit this relationship in a bit more detail by reading through your endocrinology chapter of the text. We covered the renin-angiotensin-aldosterone system previously, but let's quickly review two main functions of angiotensin II. Can you remember what they are? Awesome. Angiotensin II will constrict the efferent arteriole and increase sodium reabsorption in the proximal and distal nephron. Aldosterone will increase sodium reabsorption in the collecting tubule. Now quickly, how is aldosterone function linked to ADH secretion? Well, aldosterone increases sodium reabsorption, and this will increase the plasma osmolarity. This increase in plasma osmolarity stimulates the secretion of ADH. ADH will then stimulate increased water reabsorption to restore the plasma osmolarity. Now, as you can see, the kidney is more than just a filter for the blood. This is why some of the renal pathology that we'll get into later can be so devastating, and why damage to the kidneys is a serious cause for concern in the hospital. Now let's discuss potassium shifts. The way I remember the causes of hypokalemia is with the example of a lion that kills and eats its prey. As the lion is sprinting for the prey, its adrenergic system is activated. This activates the sodium-potassium ATPase, shifting potassium into all the cells of its body, thus decreasing the serum potassium. When the lion is eating its prey, insulin is released, which also activates the sodium-potassium ATPase. Remember that insulin shifts potassium into cells. This is desirable for the lion because the lion is eating its prey, which is a huge potassium load due to the large amounts of potassium being inside the cells of the prey. Shifting potassium into the cells of the lion protects it from becoming hyperkalemic when eating the prey. Another stimulus that shifts potassium into cells is alkalosis, such as respiratory alkalosis during hyperventilation or at high altitudes. Alkalosis stimulates the potassium-hydrogen exchanger to pump hydrogen ions out of the cell and potassium ions into the cells, causing a minor hypokalemia. Finally, hypoosmolarity causes potassium to flow into the cell, because as water moves into the cell, potassium flows with it. The reason the body does this is to restore normal acid-base status. The stimuli that shift potassium out of cells will basically be the opposite of what I just mentioned. Insulin deficiency, beta-adrenergic antagonists, acidosis, and hyperosmolarity will shift potassium out of the cells. Digitalis, which blocks the sodium ATPase, will also cause potassium concentrations to build up outside of the cells. Finally, cell lysis, such as during trauma, will cause a release of high concentrations of potassium into the plasma. Now let's look at the effects of disturbances in the concentration of potassium as well as other electrolytes. Let's start with sodium. The role of sodium in neurons is critical for depolarization and action potentials, so it makes sense that if you have low sodium, you'll have problems generating action potentials, and this could manifest as a number of neurologic problems including stupor and malaise. So what would high concentrations of sodium cause? Well, this may cause an overexcitation of neurons, causing irritability and delirium. Potassium disturbances are important because they can lead to arrhythmias. The shape of the T wave follows the potassium concentration because potassium floating out of the cardiac myocytes is what repolarizes them during the T wave. How would a low potassium level manifest on an EKG? Well, the progression of hypokalemia seen on an EKG starts with the sagging of the ST segment, flattening of the T wave, and the development of a positive U wave. And what about hyperkalemia? Well, this would be represented by peaked T waves. Low calcium concentrations can lead to tetany because calcium is required for excitation-contraction coupling in skeletal muscle. This excitability can be seen clinically as a facial nerve spasm, also called the Chvostek's sign. High calcium concentration causes renal stones, bone pain, abdominal pain, and altered mental status. Remember this with the saying, stones, bones, groans, and psychic overtones. Low magnesium concentrations can cause a prolonged QT interval, which can degenerate into torsades de pointes. And high magnesium concentration can cause decreased deep tendon reflexes, lethargy, as well as cardiac electrical dysfunction. Low phosphate concentrations leads to bone loss and osteomalacia because phosphate is required for hydroxyapatite formation in the bone. High phosphate concentrations will lead to renal stones, metastatic calcifications, and hypocalcemia. Flash quiz. What are the effects of prostaglandins on the glomerulus? Prostaglandins cause dilation of the afferent arteriole and an increased glomerular filtration rate. Remember that prostaglandins act locally as paracrine hormones in the kidney, and that NSAIDs will lead to constriction of the afferent arteriole by inhibiting prostaglandin synthesis. Let's finish up renal physiology with a discussion about acid-base. What is the normal pH of the blood? Well, it's about 7.4, and this is a number that's very carefully regulated by the body. The main buffering system in the blood uses bicarbonate and CO2. Any excess acid in the blood can combine with bicarbonate to produce CO2 and water. This keeps the pH relatively constant. In a similar way, any excess base in the blood can be neutralized with a hydrogen ion, keeping the pH constant. Even though there are a number of other buffers, this one is the most important. In metabolic acidosis, we know that the pH is decreased because it's an acidotic state. How will the bicarbonate level change? The bicarb level will be decreased in metabolic acidosis. How can the respiratory system compensate for this pH change? Well, to counter metabolic acidosis, our body's attempt to induce respiratory alkalosis is done by hyperventilating. We blow off as much CO2 as we can so that we can try and normalize our blood pH. In metabolic alkalosis, we know that the pH will be increased. Now, because it's metabolic in nature, this means that the bicarb will also be increased. Therefore, what will happen to the pCO2? Well, it will be increased due to the compensatory hypoventilation. This is what happens when we eat a big meal. When the gastric parietal cells secrete hydrochloric acid into the stomach to begin the digestion of food, they also secrete bicarb ions across their basolateral membranes into the blood, causing a slight elevation in total blood pH. In order to compensate for this alkalosis, we start hypoventilating in an effort to retain as much CO2 as possible. In layman's terms, this is what's called a food coma. This term isn't at all high yield, nor will you see it on your board exam, but hey, now you know the physiology behind it. In respiratory acidosis, the pH will be decreased. So what will that do to pCO2? Well, the pCO2 will be increased. The higher the concentration of carbon dioxide, the higher the acid in the blood. Can you think of one clinical situation that may present as respiratory acidosis? Well, opiate overdose, i.e. heroin, can cause a respiratory acidosis secondary to respiratory depression. The patient slows their respiratory rate, leading to CO2 buildup and subsequent acidosis. How do you think the kidneys will respond to this? Well, they'll try to increase their bicarb production. Do you remember the name of the enzyme that turns CO2 into an acid? Carbonic anhydrase. In respiratory alkalosis, the pH will be increased. So what will this do to the bicarb? Well, first we have to understand that the pCO2 will be decreased because excess amount of CO2 would have to be blown off in order to cause an alkalosis. Therefore, the kidneys would respond by decreasing the bicarbonate production, so bicarb concentration will be decreased. Can you think of a commonly tested medication toxicity that might predispose someone to respiratory alkalosis? Salicylate overdose. For the exam, you should be familiar with the concept behind the Henderson-Hasselbalch equation. This equation relates the concentrations of bicarb, carbonic acid, and carbon dioxide to the pH. I like to think of it very simply as higher bicarb will increase the pH by binding to hydrogen ions, and higher PCO2 will decrease the pH because carbon dioxide forms hydrogen ions. You might say, hey, doesn't carbon dioxide also form bicarbonate? Well, yes, it does, but remember, the pH is a measure of the hydrogen ion concentration and not the bicarb concentration. Let's look at some terminology. Something ending in osis refers to a process that tends to shift the pH in a certain direction. For example, an acidosis is any process that tends to make the pH lower, and an alkalosis is any process that tends to make the pH higher. However, those words don't directly refer to the pH of the blood, since there can be multiple such processes that exist at the same time. In other words, just because you know someone has an acidotic process occurring, this doesn't mean that they have an acidemia. Another useful distinction to make is metabolic versus respiratory. Respiratory processes are those that are caused by changes in CO2 ventilation, whereas metabolic processes involve changes independent of the lungs. So before we go through specific causes of acidoses and alkaloses, remember that a metabolic acidosis has low bicarb as the primary disturbance, and this causes what respiratory change? Hyperventilation, to get rid of the CO2 as compensation. The reverse of this is a metabolic alkalosis that has high bicarb as the primary disturbance, and this causes hypoventilation to hold on to CO2 as compensation. For the respiratory conditions, the compensatory response happens in the kidney, which can increase or decrease the amount of bicarb that's reabsorbed. One important point is that metabolic compensation in this way takes about 24 to 48 hours, whereas respiratory compensation by a change in breathing can happen immediately. Here's one more shortcut you can use to identify whether a disturbance is primarily respiratory or metabolic. If the pH and PCO2 are moving in the same direction, then the primary disturbance is metabolic. However, if the pH and PCO2 are moving in opposite directions, the primary disturbance is respiratory. This works whenever there is only one primary process occurring.